Welcome to The Point. Today, our focus is mostly COVID-19 impact on West Bengal with the overall context of India. As a note to the live audience, please submit your questions on Facebook Live. Panelists here are providing their views as medical experts and not speaking on behalf of government or their associated organizations. Today, we are fortunate to have three medical experts in the panel. Dr. Suresh Ramasubban. Dr. Ramasubban did his MBBS from AFMC Pune and subsequently did his post-graduation in internal medicine and subspecialty training in pulmonary and critical care medicine from Rush University in Chicago. He joined Apollo Gleaneagles Hospital in Kolkata and had been in charge of ICU from 2004. Dr. Ramasubban is one of the best critical care specialists in West Bengal. Welcome, Dr. Ramasubban.
Thank you very much for the kind words.
Dr. Subhashis Saha. Dr. Saha did his MBBS from Medical College in Kolkata, followed by MS in General Surgery from PG Hospital and MCH in Pediatric Surgery from NRS Hospital. Among many recognitions, Dr. Saha received his prestigious Uma Rani Saha Gold Medal in Surgery by the Association of Surgeons in India, West Bengal chapter. He's a consultant pediatric surgeon at a number of hospitals, including Calcutta Medical Research Institute, AMRI, Dhakuria, and Mukundapur, Columbia Asia Hospital, and Genesis Hospital. Welcome, Dr. Saha.
Yeah, thank you. Good evening.
And we have Dr. Sourav Datta. Dr. Datta did his MBBS from NRS Medical College and his master's in surgery from Grant Medical College and JJ Group of Hospitals in Mumbai. Dr. Datta is consultant head and neck oncosurgeon at Narayana Super Specialty Hospital in Howrah. Prior to this, he was with Tata Memorial in Mumbai, where he completed fellowship in head and neck surgery. Because of his surgical and academic excellence, Government of West Bengal has appointed him as consultant head and neck surgeon at PG Hospital. Dr. Datta is also patron of Voice of Tobacco victims. He also was a primary medical consultant for the much acclaimed movie Contour, which is about an artist who loses his voice. Welcome, Dr. Datta. Thank you so very much for sharing your time. And thank you for the great service you are doing to the nation and the people. We appreciate everything you do, day in, day out. Now, let's set the context. India's death toll stands at roughly 1,230 with 37,000 confirmed cases. Put it in context, that's roughly similar to Florida. The difference being India is a country of 1.3 billion and Florida's population is about 21 million. Around 4% of India's tests are positive. This is, as you are looking at, last several days, 2 weeks. It's well below the benchmark from a good standing standpoint. It's also significantly lower rate than US. US stands at roughly about 17%. This is very good news for India. Now, what happened? How did we get there? Did the virus strain change in India? Did it mutate to lose the R0, which is the transmissibility? So it doesn't spread much. We'll know more as the authorities study that. There are other possible theories we hear. None seem to be standing on its own as fully vetted ones by the global scientific community. We are hearing immunity through BCG, warmer weather. We know India has younger population, roughly 44% of the population, 24 years old or younger, compared to 23% in Italy or 29% in China. Which factors played in? We don't know. We can talk about it. Now, all this seems very good news when you compare the devastation compared to Western world. Still, there is some amount of confusion, some amount of lack of transparency that leads to fear and fueled by social media, messaging and other newses. Now, let's just quickly recount some facts here. Census in 2017 said, and this is before pandemic, right? So 22%, only 22% of deaths are registered deaths, medically, or 22% of registered deaths are medically certified. That means majority of deaths, the official cause of death has not been certified by a doctor. This is not media talking. This is census saying. And it's also very interesting to note that mortality rate sharply declined during this COVID-19 crisis. Obviously, strict lockdown must have helped cut down the number of probably traffic accidents there. But is there a case of relatives sometimes not reporting family deaths? Now let's talk about West Bengal perspective quickly. As of April 30th, the controversial death audit committee assessed death of 105 patients who had tested positive for COVID-19 and attributed only 33 deaths to the coronavirus infection and another 72 to severe comorbid conditions. Now, this committee is no longer apparently active in making the death attributions anymore. That's kind of the context as we understand from a layman's perspective. Now let's hear from the experts who have been in this field fighting day in, day out, and who are learning lessons. What lessons can you hear from them? So we know now that the lockdown is extended for another 2 weeks, easing restrictions gradually, which is great. But what do you expect to see? And how should people prepare for the next stages? What's your key observation as you see from the front line? And what's a good testing program looks like from your perspective? What's been adopted so far? And I know that things possibly be changing over time. So let me invite Dr. Ramasubban first to give your perspective on some of these things.
Thanks, Raj. I think working in a private corporate hospital or a fee-for-service where patients have to pay to be seen, We do, despite that, we are not a designated COVID hospital by the government of West Bengal. We still, unfortunately, we have one of the busiest emergency rooms in the private sector, and we do get a footfall which is significantly high. Even despite the lockdown, we still have we're running about an 8-bedded ICU and a 14-bedded isolation ward for these patients, and we have been continuously full in the last 35 days or so of the beginning of this lockdown and beginning of this in India. What we are seeing is the rates of hospitalization are not very high as compared to, say, New York or China. What we definitely, I cannot comment being working in a public sector or not being an epidemiologist about the rates of infection, but definitely what we are seeing is the rates of hospitalization are not very high for us, in the sense, like, if we look at severe acute respiratory infection, that is SARI, which is one of the fundamental things in which we are allowed to test even without a hotspot or even without an epidemiological history. In that context of patient presenting with severe acute respiratory infection, that means fever, cough, breathlessness, we are looking at an average 3-day footfall of about 90 in our fever, cough, and cold triage, in about 30 a day we are looking at. And we are looking at of that, about, if you leave out 5 or 10 who are kind of paranoid and not the true ones, we're looking at about 20-25 emergency of a private hospital with fever, cough, and cold. Out of that, we would say only people who require hospitalization, that means SARI who requires hospitalization, that means is in Wuhan, it's about 14%. In the US, it's about 30% who require hospitalization. We are requiring hospitalization about 10% of these group of patients. And we have been able to accept only a few percentage of that. So we would still say that the rates of hospitalization is not very high. The number of sick patients are not that high that we are seeing. Maybe it's a different issue when you hit the public sector and when you hit other different designated COVID hospitals. But for us, yes, we are getting sick patients who are SARI, who are going to be tested positive, who have been tested positive, have been referred to the designated hospitals, or if they're too sick, they cannot be transferred, we get them in and admit them and take care of them. What we are seeing is a lot of SARI, but not as much as we would have expected in an epidemic situation. Definitely, I think the amount of social distancing seems to have worked, in the sense, like, our system has not been inundated. We've been able to handle the system, whether both private as well as public has been able to handle the system so far without much of a stress on their situation. And as you rightly said, somehow all other diseases seems to have vanished. We have had no road traffic accident. The only trauma was somebody's glass window fell on them when they were cleaning, and it broke and it hit her chest, and she had to be sutured in the emergency room. That's the only trauma we have seen in a big, busy trauma and emergency room. We have seen pretty much no myocardial infarction. We had only one pacemaker done in the last. We have had only 1-2 angioplasties done in the last 10. So we are really looking at diseases somehow going in hibernation. So I would say that overall everything is low, and I haven't heard from any of my family members that somebody has died all of a sudden. Can you give me a death certificate? Kind of a thing happening from our patient group, from our 250 group of doctors practicing in our unit. We're not hearing a huge number of deaths, which is saying dropping dead for no reason. So I would still say rates of infection, maybe none of us are epidemiologists here. We're all practitioners. So none of us actually know the true rate, but I think most of us would believe that the rates of hospitalization and the rates of death are not really that high we are seeing here. Reasons, I think we can discuss as we go along.
Oh, that's great. That's great. Dr. Saha, give your thoughts on some of these key issues that you are finding from your perspective.
First of all, I would like to admit that I am not a frontline warrior, as you have said, taking into view that I am not a medical practitioner. I mean, I'm a surgeon, a pediatric surgeon. We treat surgical diseases of children, unlike my previous speaker, who is a direct, he directly attends to and treats people with SARI and other respiratory issues. Now, we have patients in our ward who have been admitted with pneumonia. Like when the lockdown started, 3 days later, we had a small child, 1.5 years old, who had been suffering from severe pneumonia for 3 weeks. This child has been admitted in a Durgapur a private hospital for over 3 weeks, given antibiotics, but didn't respond. There was high fever, entire lung, I mean, we call it empyema, that's pus inside the thoracic cavity on the right side, and a lung abscess on the lower lobe. So entire lung gone. And then the scare of this coronavirus has just started, maybe 5-6 days. It was fifth day after lockdown. So we were actually not very sure how to proceed, but we got all tests done. And unfortunately, this child had 5 infections simultaneously, 3 viral infections, 2 bacterial infections of the lung, some primary, some secondarily infected, but corona test was negative. 2 successive tests were negative. And so my point is, so it's not really the prevalence of this disease as we find in our clinical, I mean, patient footfall with classical respiratory issues and COVID-19, this combination is not that common in our view. Now, this child went home hale and hearty after we did a thoracoscopic decortication, and the child has been on follow-up and doing well. So my point is this lockdown has been definitely effective, although the question remains that this is a temporary measure. What next? Ad hoc extensions for 2 weeks, another 2 weeks, another 2 weeks. So what next? So we actually need to know the natural history of disease. So what is the normal course of this disease, when it is going to end, and how this lockdown is going to influence the outcome? That will depend on. So what we can say is that lockdown has definitely delayed the onslaught of disease, the onslaught of the, and allowed us to get more prepared. Now, what will happen beyond the lockdown periods is anybody's guess. Definitely the infection is going to go up, but by that time, if the natural course of disease can restrain the infectivity and the prevalence, so then we might be blessed.
Thank you. Thank you. Dr. Datta, your observations so far?
First of all, I would like to thank Dr. Ramasubban, because it means what I wanted to say. Actually, again, I am not the frontliner like Dr. Ramasubban, because I'm basically an oncosurgeon. But presently, due to as I am attached to both private and government sector, so I can see closely how the things are going on. And what he said, actually, I am talking everywhere. There are 2 things. I am directly going to controversial things, because both of them have said the means basic things, but I really want to the controversial things, which everywhere it has been projected that India is not doing enough tests. Specifically, Bengal is not doing enough tests. There are a lot of COVID patients here and there, and we are just undermining the number. So this may be true, or this may be false. But whatever it is, I am really, really happy with the situation. If it is true that actually we are undermining reporting, that means today the number is around 39,000 in India, which is officially reported. Actually, according to some people, that it is only 10%, 20%. Even if I think that it is 50%, then it should be around 80,000, something like that, actual number. So if there is 80,000 infected patients, infected persons in country, or maybe more, much more than that, then where is the number of patients with acute crisis? That means what Dr. Ramasubban said, that I am telling you, most of the government hospitals, most of the private hospitals ICU are empty. Because if there is a slightest of patient with respiratory infection or respiratory trouble, maybe it is due to even heart disease, people are referring to COVID hospital. So you can see that there are a lot of patients in some designated COVID hospital, but otherwise, most of the private hospital, even in large government hospital, the beds are vacant. That means the critically ill patients number are less. So if a large number of people are infected, then the acute symptoms are less, or the clinical presentation is less virulent in our country. That is number one. If it is true that we are under reporting. Now, actually we are reporting correctly. If we are not reporting under reporting, we are reporting correctly, then also I am very happy. If after so many days the number is 40,000, we are talking about lockdown, I totally agree. But you know, in our country, there are huge number of people. I just forget the number. I saw a few days back in newspaper that where so that is not possible social isolation, because in a 10-foot by 10-foot room, 5 people stay. And I know in areas, some areas in Kolkata, people sleeps in means slot wise. So some people, they enter into the room in the morning and they go to the office and they go to their work in the afternoon. Then another batch comes and they sleep. So this is the idea of, so means even if we do total lockdown, this will be, social distancing totally is, it's really impossible in our country for a majority of the people. So in spite of all this, if we are not seeing a huge increase of SARI cases across the country or state, then I'm really hopeful. But only one point, that what Dr. Ramasubban again told, I would beg to differ slightly. Yes, I go to PG hospital, ENT department, and there is head neck surgery. I see head neck surgery patient. So average, I see in a day around 50 patients for head neck with head neck cancer in PG hospital. Last one and last after lockdown, on an average, I am seeing 2 to 3 patients in the OPD. So it has decreased so much. But like I know road traffic accident has decreased significantly, that we can explain. I don't know cardiac things has decreased, but I don't know that maybe office related stays are less, whether it is contributing or not. The cardiologist or Dr. Ramasubban can talk about it. But regarding oncology, I know a lot of patients, they are not getting treatment. They are regularly contacting us. They are not being able to come to us because they don't have vehicle. And this effect is much more in private sector, government sector compared to private, because in private people can arrange their vehicle and the rates are very high nowadays. So I can see what is my what I am thinking, or I am really afraid of that. After this COVID thing, we may see that the damage due to COVID is much less than the collateral damage we have done during this period. So I am really scared of that, and that data is really yet to come.
Thank you, Dr. Datta. It's tremendous amount of knowledge that you are sharing here. I think the alternative, different views are very important. The direct death versus the indirect casualty, which we are going to see in many different forms, but it'll be probably very difficult to assess as well. Let me get back to the testing question or the overall regime that we have, and I don't know if it is driven by different states running their own set of rules, but going back to Dr. Ramasubban, From the testing perspective that you see both in West Bengal and overall India, what's your thought? Is it enough? Number one, um, and if so, when the lockdown ends, what strategy would be most effective at that time, if it is effective now? Um, and how do you view that?
Yeah. No, I think that right now we are one of the private, few private hospitals that allow testing. So we are capable of doing anywhere from, it's again limited by the number of kits that we have. So there are different kinds of tests that we do. One we are doing is what is called as an RT-PCR with RNA extraction. So that is a laborious process, and it takes about 6 hours of RNA extraction, and the microbiologists are overwhelmed trying to do it. But it's a time consuming, but that's the very gold standard as of now. The other RT-PCR, which are point of care, which is cartridge based, there is we have something called a BioFire, which still hasn't launched in India, which is we have it available for doing for pneumonia panels, but we don't have it available for doing coronavirus right now. But they are going to add it, and it's already being launched in Western countries. So that will be a turnaround of 45 minutes. The other things is what is called as NAT testing, which is again same thing, but done by a gene expert, which we do for tuberculosis, which is very commonly available in pretty much every primary health center. And gene expert is also going to come up by the end of next month, cartridge, which will again give a report in 45 minutes. I think the purpose of testing during an epidemic initially is to basically isolate and triage and identify and isolate. So here what is happening is, if I were to fall ill today, and I have fever and cough, and I'm a healthcare worker, so it is very much possible that I will have it. So the idea is, if I test it, or should I quarantine myself? It's only for epidemiological purpose I need to test it. I know I'm going to have COVID-19, isn't it? So why bother? So it's all right. It's okay. I'm going to sit at home. I have the luxury, as Dr. Datta said, not everybody in India has the luxury. I have a luxury of locking myself in this room and having a window and a garden and looking out and doing all those things. And I can isolate and not test myself. And after 14 days before joining work, I'll probably test myself just to make sure my patients are safe. So I would otherwise not even bother. So it won't make any difference from that. But this is because we are already social distancing. The testing needs to be ramped up. And when we have time-sensitive surgery like what Dr. Datta has to perform, that means oncosurgery. Like we had a commando operation done whom we had to cancel because on a symptomatic test, we had a RT-PCR positive, asymptomatic guy. So these are the ones who get in and he operates, and 11 hours of surgery into somebody's mouth, Dr. Datta is going to be heavily exposed. And then the collateral damage starts, his nurse, his ward boy, his this thing, and that's where the healthcare pandemic will start. So we really need to ramp up the testing for when we start doing elective work. And that's when we need to make sure that things are, especially elective work, I'm talking about not the hernia surgery or the hydroceles and all those things. We are talking about time-sensitive surgeries, which if you have chewed tobacco and you've got a fungating mass in your tooth, you got to get it out as soon as possible. And Sourav has to operate on them as soon as possible. It's a time-sensitive surgery. We're not talking about emergent surgery. We're talking about not elective surgery. We're talking about time-sensitive surgeries. We're talking about somebody having a little bit of angina at home and avoiding coming to the hospital. These guys will now come when they have a little fever and the breathlessness goes. They are tolerating the angina with a little bit of sorbitrate right now. That's why we're not getting the admissions. These guys will come in droves when we start opening up and the lockdown lifts. That is when I need testing, because the system is such that you are going to get your average list, as he said in his OPD, in a government hospital is 50. Believe me, we have 35 patients on radiation every day. We have 280 patients on dialysis every day. We have 45 daycare chemotherapy every day. And we are talking about a large hospital. So I think every hospital which is large enough in India will have numbers which are equal to what is done in the whole of Dallas. So each one of us will be doing that kind of numbers. So when you're looking at that numbers, if you get one infiltrator, that has been one positive in the chemotherapy, daycare chemotherapy, all 45 on that daycare chemotherapy are going to go. Because it's that is when our problems are going to start. So I think we have definitely flattened the curve. The system is ready, but have we geared up to ready for testing when the thing opens up? I think we are still not ready. So I would like the lockdown till I get my NAT and my gene expert ready. So May 30th to June 15th is when I want my things done. Till that time, it is going to be very selective time surgery where I cannot postpone for more than 2 weeks. I have to be very careful, but routine, I would say I'm not ready. We are not ready. I don't know if we can speak for others.
Yeah. So 2 weeks, getting 2 weeks is great, but you need a little bit more runway, is what I'm hearing. Do we have enough confidence? Yeah. Do you have enough confidence that you're gonna get that? Number one, you're gonna get that runway. Number two, you're gonna have enough ramping up of testing where you feel comfortable that this is possible.
So if gene expert is similar to gene expert kind of a thing, because every primary health center in India has that kit already because of tuberculosis. So it is not very difficult to ramp it up from a public perspective. It is just the cost of the kit. And if the government of India buys 100,000 kit or government of West Bengal buys 20,000 kits, then pretty much every primary health center will have a kit by tomorrow. So that's for sure. It's only whether the manufacturing is approved and FDA approval and it comes to India.
Got it. So cost is also a major part of this equation, and I understand it's very hard probably for all of you to comment on cost, but Dr. Saha, do you have sort of an opinion on that, how it should be handled, given that yes, many people today from middle class families probably can afford some of these costs, but then when you are looking at the mass in general, and this is not a subject where you are just dealing with singular patients or just a group of patients. This is where everybody's health or public health is mostly affected. How do you shape up the conversation at a larger scale where perhaps there is a little bit more understanding on how it can be affordable by the mass? That's one question, Dr. Shah, and if you could comment on the hospital capacity once the lockdown ends and things start to begin.
Yeah, so the first point, I mean, I think it has been very nicely summed up by Dr. Ramasubban that this NAT, CVNAT, and this gene expert, these are actually already the infrastructure is there. So government needs to put in little effort to supply these kits to the district and the health center level. So that's very important. And I think two other very important points are the health workers, the extensive risk of the health workers. Once the testing is ramped up, I think that health worker risk also comes down, because especially the anesthesiologists and the ENT surgeons, Dr. Datta will be able to tell us. Now, aerosol generating procedures, there are a huge list of procedures, and intubation. That means whenever a child or a person is anesthetized, the anesthetist bears the maximum brunt of the risk because the aerosols are generated if the patient is infected in case. So, I mean, this spreading of an infection, just as he told, that one infected patient in a ward can lead to quarantine of maybe 150 and 200 people. So once we start testing, like as now it has been ramped up, we are doing RT-PCR in so many patients, in almost all patients needing emergency surgeries and all. So we are now at a much surer, we can be sure of ourselves that at least 2 tests testing negative, that this patient is a negative and we are safe. That is one aspect. And the other aspect is the moment lockdown ends, a lot of patients will come in for the treatment of semi-emergency things which have been on shelf till date. Now, we need to really screen those patients very sincerely for COVID disease. Otherwise, the spread will be immense. And regarding the setup, I think there is some statistics which told, I mean, that was a study done in Harvard, which said that per 100,000 population, there has to be around 3.2 ICU beds. Now, China had 0.3 per 100,000. US has 10 times of that. So now you can just imagine that even United States, now comes the question of whether the mutant of the virus, which is now in our country, is as bad as that in the European countries or the United States. Or is temperature playing some role? Or is the BCG vaccination or our innate immunity playing some role? Keeping aside all those factors, the standard recommendation which I told, that 3.2 ICU beds per 100,000 population, India falls far short of that. So one can really imagine that if there is a exodus of patients after lockdown, what will happen? But fortunately, the indicators are not like that. The indicators are telling us that there is a high possibility that this will not happen. And if we have more and more of epidemiological screening testing, and thereby locating and isolating and defining, as it has already been defined, red zone, green zone, and yellow. So if the lockdown relaxation is phasing, so that we can, as is being done by the government rightly. So if this protocol is followed, I think there is we can get over it.
That's very good to know. We have audience here. A lot of them are from US, and they have their loved ones back in India, specifically in West Bengal, Kolkata region. So some of the things that go kind of on people's mind, because their loved ones are there, a lot of them are aging. What kind of specific risk you see, and Dr. Datta, if you can give from your experience, now that we are in lockdown, a lot of folks are not coming out who need medical attention today, but they are kind of gearing up for tomorrow when things open up. What kind of advices you have for this population, and what would you suggest to do now and when the lockdown kind of ends?
Look, it's very difficult for me to say, because I know a lot of people, they need immediate medical attention or something, a medical treatment. They are not being able to get the proper treatment because, at least from my experience, I can tell that even with any acute condition, it is becoming very difficult for patient to be getting admitted in different hospitals in West Bengal. This is a real acute crisis situation, and the first thing government should do, and I think day before yesterday, government has issued a circular also that all private hospitals should function normally. It is getting difficult to take care of the patients. But regarding means, I don't know. It's really honest confession that it is really getting difficult for our own people to get admission in an hospital if they are suffering from some acute disease. I don't know whether Dr. Ramasubban or Dr. Saha would agree with me, because I have, as I have a lot of social interaction with a lot of people, I am getting requests almost every day from some people regarding immediate medical advice or something. And truly speaking, most of the time we are also clueless. So this is a situation going on. So for that reason, I am repeatedly saying everywhere that COVID is a definitely a real crisis. But for me, a myocardial infarction or a oral cancer or a pancreatic cancer or a acute kidney disease is maybe more severe. Clinic as a medical point of view, these are more severe disease compared to most of the COVID patients. I know a lot of COVID patients. Even I will not tell them patient. I think whether Dr. Ramasubban or Dr. Saha would agree with me, because there lot of medical professionals, sisters, doctors, they have become positive because they were in contact with some positive patients, so they were tested and they become positive. They are in hospital, not in home quarantine. They are in hospital without having any clinical symptom. So ICMR data shows 80% of COVID positive individuals in our country are totally asymptomatic or with little bit symptom. Having said that, uh, this can become really dangerous to people with old age or with comorbidity. We have to take it in mind. But what Dr. Ramasubban said again, that regarding testing, we have to carefully do it because we have limited sample. We don't have means n number of samples that whoever wants, who can do it if he has money or if government wants. It's not like that. You know, a lot of kits we have to send back to China because they were defective. So there are shortage of kit also, and we have to really use it carefully, judiciously. And regarding the other patients, I'm really afraid when the lockdown will over, whether there will be a crisis of beds for these patients in most of the hospitals. I'm really scared of it.
Okay. Okay. Um, Dr. Saha, we have a question from the audience. Um, Ognimitra Bishwas is asking, we heard about 3 strains of COVID, A, B, and C, and it seems India has got mostly COVID B, which is less virulent. How frequently the virus can mutate between these 3 strains?
I am not an expert in this field. I'm sorry. I would not take the question.
Okay. Dr. Ramasubban, you want to?
Yeah, I think whatever experience we have is with dealing with influenza, H1N1. That's what we would always say has been the last shift in the antigen that we have seen that happen. So drifts happen all the time. Shifts happen once in a few years. That's what happens in influenza. We don't know whether we can easily translate this data from influenza to coronavirus. I don't know. I don't think any of us, actually any microbiologist, also has an idea whether it will be. But since it's just a 54-letter viral RNA genome, so I don't believe it's very difficult to change from one to another. It's not like a human genome where you have a lot of alphabets. So
quite easy.
Yes, I think these are 3 virulence genes you're saying. Is one is more virulent, other is more virulent. So the indoor variety, as we call it in our circles, is that people in indoor are dying much faster than other parts. So there is a variety in India which is also causing harm. So maybe that somebody travels from Indore to Calcutta will get this in here. So that's not a big issue. I think the boundaries have been diminished from air travel and from road travel. So I don't think if you have 3 variants or 5 variants, it's not going to make a huge.
Doesn't make, yeah.
Huge antigenic shifts and those kind of a thing becomes an issue only when you have a vaccine and things like that. So right now, I would probably not worry too much about it.
Okay. Now let's talk a little bit about the vaccine and perhaps treatment. Dr. Saha, in your observations so far, I know there are a few things that that you are dealing with and maybe helping with. One being plasma therapy on one end, but also on the other hand, you are observing, all of you are observing work that is going on in within India, UK, US, and elsewhere, where there are obviously tons and tons of scientists are spending day in, day out in figuring out the vaccine. So question is, what is what is, in your view, maybe the path in the short run before the long-term cure comes into play? What are the options?
Now, two things are separate. One is a vaccine and one is concept of plasma therapy. So I would just take the second one first. Now, plasma therapy, as we all know, I mean, that's one of the fallback options for us, for the critical care people, when they have exhausted everything. Because till today, we do not have any definite medicine, definite cure for coronavirus, for COVID-19. So we have a lot of arms. So there is a solidarity trial going on. So there are many arms. Like here, we do not have, most of remdesivir is not available. So once upon a time, people, all the health workers, I know, my friends, a lot of my friends, in fear, they started taking hydroxychloroquine, thinking that might. So that theory is now out. So now we have many, many options, but none of them is proven. So now if a patient starts getting very critical, now as a last resort, we can, of course, try a short-term treatment, that is convalescent plasma. Because convalescent plasma is a person who has been cured of COVID-19. So he's supposed to have enough antibodies in his blood once he gets cured. That is at least 28 days after his infection. So that might help as a depot of antibodies. If it is after proper processing, if it is transfused into this person, a few cases have been shown to have good results. Of course, there could be a lot of adverse effects. So it's not a prescribed thing. So ICMR has started a trial just on a research basis under some very, very critical patients. So that is one aspect. And we all know that the only thing that can solve this problem forever is a herd immunity. That's when more than 50% of the population in the society gets infected with the virus, it is no longer going to spread. That's number one. And number two is a vaccine. So a vaccine is a much more potent and permanent solution rather than this plasma. Because plasma had ready-made formed on antibodies, which is not going to stay for long in the circulation. But on the other hand, this vaccine is going to stimulate your immune system to produce antibodies, which is going to there for a pretty long time, maybe a year. So there are almost more than 86 candidate vaccines which are being developed all over the world, various places in China, in Europe, in United States, United Kingdom. A lot of work is going on, research is going on, and vaccine trials, some are in phase 1, some are in phase 2. But one we all know human trial has started for a vaccine which has been developed by the Oxford University. And we are fortunate that one of the Indian companies, Serum Institute of India, based in Pune, has partnered with Oxford. And that vaccine, so it's part of that same project. And I would like to mention here, I'd like to congratulate, and it's a big step. The CEO Poonawalla and his father, they have invested a lot. I mean, they have invested almost $30 million to develop this vaccine and make it affordable. Now, till now, this vaccine holds a lot of hope. That is because we know that animal trials have been done. 6 rhesus monkeys have been infected with coronavirus, and they have shown pretty good result after administering this vaccine. So Serum Institute is going to produce these vaccines in a large number, and by the end of maybe October, we are going to have a lot of vaccines. But unless it is clinically proven that it is safe and really effective, which probably by the year end will be having those results with us. So that is one of the way to go forward. And the most important is they are apparently trying to make it at a very affordable cost. I mean, affordable to many of us, may not be affordable to many of us. It is almost, slated to be around 1,000 bucks, rupees, INR. And if government takes up this project and provides at a subsidized cost or at free, of course, time will tell.
Thank you. Dr. Dotto, Dr. Ramasubban, do you want to add to the vaccine and the treatment perspective?
See, I'm involved in a lot of, so we are treating a lot of patients who are acutely ill in ICU on a ventilator. The problem with convalescent plasma as of now is none of the centers in Calcutta or in West Bengal have the ability to detect antibodies. So none of the blood banks. So we are also an ICMR. We've been part of, we're enrolled in the trial, but we still don't have the ability to measure it. So if we don't measure if one of us, and most of our patients have recovered, and you have to be group specific. So you have to have, say, if somebody's A blood group, so you have to get A positive plasma for them. So the ability to do plasmapheresis is there, the ability to do this thing is there, but we still don't have the ability to check both IgM and IgG antibody in plasma as of now because of the availability of kits in blood bank. And then to do a quantitative IgG levels to see whether they actually have good sufficient amount of antibodies is also lacking as of now. So as of now, all treatment that we are doing, whether it's hydroxychloroquine, ritonavir, lopinavir, or we are even trying the IL-6 antagonist. We are trying that. And in those situations also, we are following what is IDSA guideline. All medicines are to be given with under the under the governance of a clinical trial, and we take consent accordingly that this is probably part of a, we really don't know what is going to happen and doing that. So therapy wise, as of now, there is none of the medications have shown to decrease mortality. They might decrease a viral shedding and time to positive conversion, time to negative conversion, but there is no real outcome benefit that is happening in any of these therapies. So the IL-6 antagonists and steroids have been tried in patients who are getting onto ventilator, but the data on that is also, as I said, very sketchy and not very strong. Vaccine, as far as is concerned, I think that's a field which Dr. Saha covered it very nicely. It's that is the between herd immunity and vaccination. I think vaccination is a better option because it gives less morbidity. So if we can get the vaccine out, but I would say still the best chance of getting a vaccine into the market would still be even the fastest approval process, fastest phase 3, phase 4 trials would still be, would leave you about 9 months to a bare minimum before you get a first jab. So I think we still have a long, long way to go on that.
Thank you. Dr. Datto, any opinion on that?
No, I think both of them have covered very nicely. I think everything has been covered by both of them.
Okay, great. Thank you. We have some questions coming online. So let me look at that quickly. Let's see. So one question is from Rinki Debray. While all the schools are currently conducting online classes, the exam boards have decided to conduct their postponed board exams within a few days. What will be the advice to the boards? How will they avoid children getting affected?
I think in India, I think they anyway take care of social distancing in the board exam because they're cheating. So you anyway have social distancing there. So I think we will still be all right in going for the boards. I don't think boards are going to be cancelled despite our best wishes. I have my daughter in class 10, so she's praying with sincerity that it gets cancelled, and I understand that. And so if they could all go to the next session without going to the boards, welcome for all of us parents. My wife would love that.
Okay. Okay, that's good. That's good to hear. Now, there is one more question from the audience. We kind of touched on this, but since this question came up again, let me ask. Ryan Chaudhary from Dallas is asking, we hear news about senior citizens denied access to basic healthcare in West Bengal, resulting in death from otherwise non-life-threatening condition. Some in other states as well. There seems to be much confusion about which hospital to head to. Is there any guidance on that?
Let me start. Go ahead, Sourav.
So that point I was repeatedly saying during this discussion There are a lot of confusion going on everywhere. But I think government of West Bengal, at least in West Bengal, they have clearly they have clearly given a directive to all the private hospitals and also to the government hospital that you cannot deny people, you cannot deny patient, you have to admit them. And I think means it's my means presumption that from next week onward, I think we will see a change. I don't know what is your opinion, Dr. Ramasubban, but I really think that I have from lot of hospitals, as I'm attached to one big group of hospital in Kolkata, private group, and I can means I can sense that they are becoming ready to be functional almost in normal in next 7-10 days.
No, I think I agree with you. I think the emergency is fully functioning because when I'm on call for this thing, it is extremely busy to go down to the emergency and see these patients. What is happening is if there is some suspicion, so the problem comes when you have either fever, cough, or breathlessness. So if you have a stroke, it's all right. If you have a when you have either of these things, fever, cough, or breathlessness, that's when the panic button starts hitting. And then it comes. So if you have a renal failure and you missed a dialysis and you now are breathless because of volume overload, your X-ray will look dirty, and you are going to be the emergency is going to be afraid of you, and that is happening. So I think in this situation, what is happening is the facility for us to get them screened, isolated, and then admitted. The process is slow, and I think all hospitals are working to streamline this process. When you come in with a not a typical symptom, how to admit and how to do it. But we are still functioning. We are still not refusing anybody. Obviously, if you're then in initial screening, we are doing with X-rays and ultrasounds and CTs and so on and so forth. And if we find that you're suspicious, then we are referring them to a COVID-approved hospital. If we find that you have no reason to be sent to have suspicion of COVID, we are definitely be able to give treatment. But as I said, we still are not getting that many number of patients walking into our for other emergencies. So right now, yes, as Dr. Sourav says, 5-7 days, we probably still require another 5-7 days to prepare ourselves to have a holding area where you have been screened in the emergency, but you're not admitted to the hospital, and that holding area concept is what is taking place. And we're still working on the way of testing these people in the holding area and getting some amount of clearance by either symptomatically or by other indirect tests so that we can again admit them into the hospital. So we don't want them to come into the hospital and be next to a good patient, then they are an immunocompromised, a transplant patient, or cancer patients. And so there has to be, hospital also has a job to be safe for the patients who are already inside, and also to the healthcare worker, and also to the other things. So the responsibility of the hospital is not only to the patient who's coming in, but to the patient who's already inside and to the staff who's working. This is one of the first time we always talk about patient quality. Safety has always been for the patient. Any of these quality meets, Six Sigma meets, they always talk about patient quality, quality of health service. It's the first time in our lives where, Time and Newsweek puts an anesthesiologist on the cover page, and we're understanding that right now it is both of us who are involved. It's not only you who are sick, you can destroy me also. So that's something which is different. Look, families and patients also need to understand that this is not a normal situation. No doctor would ever say no to treat a patient. And, especially, I haven't seen a single doctor who ever refuses a patient. A surgeon, I have never seen one. Physicians may still refuse. I've never seen a surgeon refuse an operating patient. If a surgeon is refusing an operating patient, that means he's senile or he's afraid. And I think there's only two reasons for that. So if you are afraid, and it's true, because you're not only going to be the surgeon, it's the poor nurse who's a circulatory nurse, your scrub nurse, your OT technician, your anesthesiologist, and so many people. The surgery is not a one-man job. Nothing is a one-man job. So if you have an infected patient who has got requiring dialysis, there are 25 patients in the dialysis room. You're not only going to go down yourself, you're going to take down 20 people with you. So I think patients also have to realize, and that's why they're not coming in that many numbers. So I think everybody understands the game. It is what, as Sourav is saying, as Subhashis is saying, we just need a little bit more preparation to have our holding area, have our screening test base. So that's what we need to be prepared for.
Well said. This has been a big problem here in the US with everything going on for safety for healthcare folks are biggest importance right now. So yeah, completely understandable. Contact tracing. This is a subject that is coming up big time here in the US. This is something that has been implemented in some of the Asian countries very effectively. So question from Shobhendu Roy is that is contact tracing a viable option in India, especially in densely populated areas? And what kind of cooperation is needed from technology or corporate sectors? How will Arogya Setu app, which is suggested by Central Health Department, help? So let's get some guidance from all of you. What you think about that?
In healthcare, today's JAMA actually has an article that probably there's no real reason for healthcare worker to have contact tracing. So we define, I also do infection control for my hospital. So we define contact as casual contact. That means less than 3 minutes of contact without the personal protective equipment, and or in close contact, any contact within 1 meter without a personal protective equipment. So with a personal protective equipment, no contact is called as a contact for healthcare worker. So I can only, our expertise, my expertise is only in hospital infection control. Public health infection control is a different ball game completely. In hospital infection control, if you have one index case, we are segregating all the patients, all this patient care services, food and beverages, technicians. So we classify them as casual contact or low risk contact and high risk contact. And then there's a WHO form that we have adapted. It's available freely. So there's a person who takes the questionnaire, and then we test them before we let them back to work and quarantine them for 14 days. So in a hospital setting, it works very well. As far as public health is concerned, I don't think I have the expertise to answer that as to contact tracing, how it can be done in a densely populated country like ours. I don't know whether the other people have any idea. But Arogya Setu is like any other app, I think, where you are going to be monitored. So it's like a tracker device. So an iPhone probably would do the same thing for you if you keep your location on. So an iPhone can locate all of you. So I think technologically, but then that's like George Orwell's time where this thing, do you want to be a citizen who wants to have his privacy at all time tracked? So I think there is going to be an issue of personal privacy if you have your phone on and you're being tracked every moment. So I think there's a balance between privacy and public risk. Again, these are big issues, which I think 3 or 4 of us sitting here who have no public policy making. These are what is called as public policy making. These cannot be discussed among a few group of friends in Facebook. And
no, but one more thing which I can add, that in India, again, I am maybe controversial thing I'm saying, that so much of centralization may not be good, one thing. And second thing, giving everything. So now I got a directive that Arogya Setu app for the quarantine people is a must. Now you tell me, do you think every Indian, they can afford to have a smartphone? Now, means in a country like us, when people are staying in a 10 foot by 10 foot room, 6 people are sharing it, and we are saying that Arogya Setu app download is a must, I really think it is, sometimes it is ridiculous. And contact tracing in a country like us, in a general population, is really difficult, truly speaking. And but still what we can say that in our country, the result shows whatever we have done, that is good enough. At least means if you talk about the result.
That's great. No, thank you. We have one more question here coming up online, let me ask that question. In what time do you think India can allow international travel? Any sense on that? Futuristic, but.
So if you are inviting us, then we can suggest tomorrow only. Dr. Ramasubban,
It will be question whether you want to come in here, right?
Right now, as even if they offer me back a job, it's not something which you want right now. So I think being a critical care specialist, so that's going to be an issue. No, I think travel will lockdown. I think these are public policies. I don't think I have the expertise to.
No, I can tell you something. I mean, regarding travel, this is going to be a stigma for a long time. Only the other day, all our all India chapters of various pediatric surgery and all specialties, we have planned for the next 1 year. All conferences we have cancelled, and probably we'll be holding all these conferences over net. I mean, the stigma of traveling is going to stay for a pretty long time. That much I can tell you. I mean, our way of life is going to change, and the social distancing and all this stuff is going to stay there for quite some time. And international travel, okay, with spacing, with all schedules in place, I think by another month end, I mean, end of June, I think it's going to start. It has to start. Otherwise, this economy, etc., a lot of things are interrelated. You cannot stop it forever. But there has to be these things, as Dr. Ramasubban has said, that enough testing. I mean, you can have at least some idea of what population you are catering to and what is the exact area of the disease and this thing.
Yeah, no, makes sense. Again, go ahead.
The idea of a lockdown is to prepare. The idea of a lockdown, second idea of a lockdown is to turn down the R0 from say 3 to 1. And this is the two ideas of the lockdown. So I think the success of the lockdown of taking the R0 from 3 to 1 has probably happened. But are we prepared when the lockdown opens is an open-ended question. I think that we probably are still not there as of yet. So I think that's what the feeling that the central government as well as the West Bengal government has. And that's why they are not in a hurry, despite the hardship to the people. They're not willing to risk the R0 jumping to 3 again just by opening it and leading to a catastrophe where you now will have a situation where the economy is already doomed and you now let the lockdown go, you're going to have a health and an economic hazard. So now that you've taken the route of health, so why not stick to it till you are prepared and then let the economic hardship is anyway going to hit. All of us are already fee-for-service consultants like our surgeons are already not made, they're labor class, they're not making any money anyway. So we're all anyway not making money. So I think every one of us is going through that phase. So it is going to be that at least keep health preserved and let the economy take a little bit longer to kick in.
Yeah, true.
It's the same debate here as state by state folks are reopening and you see people coming out in all shapes and forms and protesting and things of that nature. A tremendous amount of debate is going on reopening the economy versus costing life, basically. Very, very tough, very, very tough. What keeps you sane in this pandemic? I know you are not exactly locked down yourselves in the sense that you still have to operate in different capacities, but what keeps you or your family sane during this time? Some tips, perhaps.
We can try our hands on cooking, which is normally we don't do. Listen to a lot of music and all those things, which we don't catch up normally. We don't have time or we couldn't manage time. I think those are very important aspects, and spend time with our family members.
Yeah.
For me, I worked all 35 days of the lockdown so far. And quite a few of them are 24 hours. So I'm not saying that I've had a lockdown so far. So I'm looking forward where I can have a lockdown. welcome from me. So, but there are not many people. I think in our hospital, the 6 of us who have taken the brunt. So there's only 6 of us who are working that hard, and the remaining are
So again, for me also, onco surgeries are not going on, but still we did it till the 20th of April. We were continuing, but after that, when the cases increased, we stopped. But as I have some administrative role in the hospital as well, so I am going to hospital each and every day, and I have self-quarantined myself for almost 1.5 months. I'm not staying with my family because I wanted to keep them safe from me. So uh, uh, means I am with my some doctor friends, colleagues, and we are enjoying.
That's great to hear, and thank you so much for the great valuable information you have provided to our audience, and your service to the nation. Really appreciate that, and thank you for coming. To
Just
this
one,
session. Yeah, go ahead.
just one comment.
Yeah.
So I presume that most of the means viewers are from US and they are NRI, non-residential Indians, and they are very much anxious about their family members who are staying here. So I can tell you that we are handling the situation much better than your country, means US. So be most assured.
Yeah, no, that's great to hear. Those are very reassuring words. Thank you again. Thank you, Dr. Saha, Dr. Datta, and Dr. Ramasubban.
Thanks.
And have a great week out there. Very productive. Thank you.
Thanks.
Thanks.
Yeah, I'm sorry if